Hello everyone and welcome back. Today we are studying antipsychotic drugs. So here is a basic breakdown of today's presentation. I will be covering typical and atypical antipsychotics, their classification, general information, dosage ranges, indications, side effects, and their respective advantages as well as disadvantages. Oh, wrong way. Okay, so firstly, the typicals, also known as your first generation antipsychotics, they are dopamine receptor antagonists. The following are their classes, and you would probably recognize them by their trade name in brackets, for example, haloperidol or chlorpromazine. So as mentioned before, they are dopamine receptor blockers, but they also act as muscarinic cholinergic, alpha-1, and histaminergic blocks. Their dosing range for haloperidol is 0.5 to 15 milligrams, chlorpromazine from 200 to 800 milligrams, and the other two that I can't pronounce. The side effects for typicals, most importantly, would be the neuroleptic-induced movement disorders, acute dystonia, Parkinsonism, akathisia, and tardive dyskinesia. These ones you would see quite often when referring to side effects in antipsychotics, and they would be covered in much greater detail in the following slides. So stay tuned for that. They are quite common exam questions. And also anticholinergic side effects. But don't spend too much time on that because just know what they are, but anticholinergic side effects isn't synonymous with the typical antipsychotics because they also are a side effect of the atypicals. Not a great exam question. So the advantages of using atypical over the atypicals would be their relative effectiveness and affordability. Their disadvantage now would be their side effect profile. They have greater rates of extrapyramidal side effects and tardive dyskinesia, and they also have limited effectiveness in patients who exhibit negative symptoms or neurocognitive symptoms. Furthermore, about 20% of patients who are started on atypical do not respond to these medications. So there is a discrepancy between whether typicals or atypicals are the first line treatment. In different institutes, they would have different protocols. At our medical facility, we use typicals as first lines and then atypicals as second line. If the patient is exhibiting severe side effects, they're not tolerating the typicals, or they are not responding to the typicals, then we would move on to using atypicals. But just make sure with your institution which ones you guys use as first line. Then moving on to the atypicals, also known as the second generation antipsychotics. They are serotonin dopamine antagonists. The classes are as follows: risperidone, olanzapine, quetiapine, ziprasidone, aripiprazole, and clozapine. The most common one that I see being used at our facilities is risperidone, and then the other one of note or of importance is the clozapine, because clozapine can be used for treatment-resistant schizophrenia, and if the patient has intolerable extrapyramidal side effects or tardive dyskinesia. They do, however, have a risk of agranulocytosis and neutropenia. They are associated with myocarditis, seizures at high doses, toxic megacolon, and metabolic syndrome. Their side effects include sedation, weight gain, constipation, and increased salivation. Okay, so compared to the typical antipsychotics, they have a decreased affinity for your D2 receptors. Hence, they have a decreased extrapyramidal side effects. That is why majority of the time, that is the main motivation for using atypicals over the typicals. The dosage range for risperidone is 1 to 8 milligrams, olanzapine 5 to 20 milligrams, quetiapine 300 to 800 milligrams, and clozapine 100 to 800 milligrams. The indications for use would be severe extrapyramidal side effects from your first generation or tardive dyskinesia, mood symptoms and suicide risk, elderly with behavioral symptoms. They are also superior to typicals for treatment of negative symptoms, and if there is treatment resistance, you can opt for clozapine. The side effects of atypicals, most importantly or commonly the metabolic syndrome, diabetes, and weight gain. With regards to the cardiovascular system, they can have postural hypotension, prolonged QT interval, sudden death from cardiac arrhythmia, and cardiomyopathy. They can also develop neuroleptic malignant syndrome, hyperprolactinemia, anticholinergic side effects. They also lower the threshold for seizures, so if being used in an epileptic patient, use with caution. Then agranulocytosis, also one of the side effects. The advantages of using atypicals over typicals would be that they exhibit less extrapyramidal side effects and benefit in patients who exhibit negative symptoms, neurocognitive deficits, and mood problems in schizophrenia. The disadvantages would include the increased risk of cardiac conduction abnormalities, metabolic syndrome, and their high cost and limited availability. Here is a list of the important side effects, but I would say the most important or commonly asked ones would be number 1 to 5. So number 1 is acute dystonia. This refers to a painful prolonged muscle contraction which leads to abnormal movement or abnormal postures. For example, torticollis, trismus, protrusion of the tongue, dysphagia, and laryngopharyngeal spasms, oculogyric crisis as well. So they usually present within the first week of initiating antipsychotics or after increasing the dose of the antipsychotics. The risk for developing acute dystonia is greater in your young males and if you are using a high potency drug. The treatment then for acute dystonia would be piperidine of 5 milligrams. It can either be administered via IVI or IMI. Secondly is the side effect Parkinsonism. You can remember this with the acronym TRAP, which stands for the clinical presentation of tremors, rigidity, akinesia or bradykinesia, and postural instability. The treatment for Parkinsonism is your anticholinergics of phenadrine or piperidine. You can also try decreasing your antipsychotic drug dosage or changing to an atypical antipsychotic. Thirdly, akathisia. This refers to a subjective tension, which manifests as an objective restlessness that you can see. The patient can't sit still, or they are fidgeting, or they are rocking in their chairs or pacing back and forth in the room. This usually develops within the first few weeks of initiating treatment. And the treatment for akathisia would be a beta blocker such as propranolol, or you can change to a lower potency drug. You can try decreasing the dose or changing to an atypical antipsychotic. Then next, I would say these two are the most common exam questions: tardive dyskinesia and neuroleptic malignant syndrome. Tardive dyskinesia because it is irreversible, that's why you have to catch it early and then manage accordingly. And neuroleptic malignant syndrome because it is a medical emergency. Okay, so tardive dyskinesia is the abnormal involuntary movements such as oral movement, tongue protrusion, grimaces, chorioathetosis of the extremities, and abnormal posture, also known as tardive dystonia. This usually occurs when there's been chronic use of antipsychotics greater than 4 years. Tardive dyskinesia is irreversible. The risk factors for developing TD is in your female patients, they are elderly, and they are taking high doses of antipsychotics. How tardive dyskinesia comes about is due to the upregulation of D2 receptors due to the chronic use of these antipsychotics, and this leads to the upregulation of D2 receptors in your nigrostriatal pathway. These symptoms are not alleviated by anticholinergics or anti-Parkinson's drugs. The treatment for tardive dyskinesia, well, Technically, it can't be considered a treatment because it's irreversible, but a management for tardive dyskinesia would be first try to stop the cholinergics, decrease the dose of your antipsychotics, and maybe perhaps change to an atypical, for example, clozapine. That would be the atypical of choice. Then for neuroleptic malignant syndrome, this is now when there's an advanced dopamine block leading to advanced Parkinsonism and catatonic features. The mechanism here for the catatonic features is unknown, but it is a clinical feature of NMS. This appears within the first week of initiating your antipsychotics. The mortality is up to 30%. So it is important to recognize the symptoms, which include muscle rigidity, fever, and autonomic instability, such as the labile blood pressure and tachycardia, or diaphoresis, dysphagia, incontinence, change in level of consciousness, tremor, leukocytosis, or on your labs an increased creatinine kinase, or clinically mutism. The management of neuroleptic malignant syndrome. First of all, stop all your antipsychotics and then admit the patient either to a normal medical ward or to high care depending on their clinical stability. Exclude other serious conditions and then start with supportive therapy. Cool the patient, hydrate, monitor the vitals, and insert an NGT. If there is severe muscle rigidity, you can give the patient diazepam or lorazepam and also provide DVT prophylaxis. Avoid your anticholinergics. Take caution with renal failure, so monitor the renal functions, and if possible, cut out all the renal toxic medications. You would see that the kidneys are failing when on the labs there's an increase in creatinine kinase or an increase in myoglobin. Then the last resort treatment option, if these do not work, would be dantrolene or bromocriptine. And if still the patient is non-responsive to these prior management strategies, then try ECT. Then once the patient is stable, you can re-challenge with a decreased dose of the antipsychotic or trying with an atypical or just opting for electroconvulsive therapy if they are not tolerating the other options of management. Here is a list of the other side effects that you can go through, including the cognitive, sexual dysfunction, endocrine dysfunction, hypersensitivity reactions, ocular side effects, and GIT side effects of antipsychotics. Yes, you can go through that. Okay, so that is the end of today's presentation. Thank you for listening to the very end. I hope it really helps. And if you have any suggestions or anything that I have missed of importance in the presentation, please let me know in the comments below. Good luck for your examinations, and I believe in you. I think you can do well. Okay, see you next time. Bye.